And I remember thinking, if this could happen to me as a clinician coming in, telling people something is wrong and them minimizing my experience, it can happen to anyone. And it still happens to many people to this day. And it almost took my life. And I imagine that many women die unnecessarily because of it.
Welcome to Boundless B, the Hemophilia B podcast, the podcast standing with you from a family like yours, presented by the Coalition for Hemophilia B and in partnership with Balancing Life's Issues. Today's guest is someone who's been challenging outdated systems and winning. Amber FEDERIZO is a nationally recognized nurse practitioner, regulatory pioneer, and passionate advocate for women living with bleeding disorders. Her work has helped change how clinical trials are led, how underserved communities are reached, and perhaps most importantly, how women are heard. This conversation is about power, specifically the power of language, access, and advocacy, and how a life-changing word can change someone's entire experience of care. Welcome to the podcast, Amber.
Thank you. And it's always a pleasure and an honor to be here. Every opportunity to reach, get this education out there, reach a broader audience, I appreciate. So thank you for the invitation.
Of course. So let's start with your journey into advocacy and I think what we'll call innovation. So how did your journey in clinical care lead to the broader kind of advocacy and regulatory work you do now?
Yeah, so it's been 15 years now, which is amazing to me that it's been already 15 years. And when I first started, I realized that a lot of the questions that we thought we were asking, we really weren't. And the assumptions that were made based on not asking those questions were that people weren't bleeding or they weren't having issues or they were just fine. But in truth, the reason that a lot of data is missing is because we were not asking the questions. And so as I began asking these questions, it led to more questions and, this desire to look further into it over time. And so very early on, I started working with women and asking these questions and developing this whole clinical care that needed to be set for them as well.
Absolutely. And so what, I guess, inspired you to focus on women in rare diseases?
Yeah, so people ask me that all the time. And when they find out that my husband and my son also have bleeding disorders, they assume that brought me into the community, but they were actually diagnosed as a result of me coming into the community. I had my husband experiencing 4-hour nosebleeds, and his family had always thought that was 100% normal. And in learning through all of this, I told him that is absolutely not 100% normal. And so they were diagnosed after I'd come in. But what brought me into the focus of women was actually my own experience as a clinician. I unfortunately lost a second trimester pregnancy, and I was taken to the ER because I was bleeding too profusely. And originally I had been told this miscarriage will be similar to sort of a period. You'll have cramping, you'll have pain, but it won't be so bad. And when I got to the ER, I knew something was wrong. You just get this feeling, this sense of impending doom. Something is wrong. I had tried my best to stay home. I, as many healthcare clinicians, avoid going in with as much of my fiber being as possible. So when I was brought in, it was still that same story of just let it happen. It's a miscarriage. We're just going to put you in a room. We'll give you your privacy. And I had the most extreme pain, and they started giving me pain medication. And I, over the course of a few hours, started to really get really tired and cold. And so they kept bringing me blankets, bring her comfort. And I wasn't, on a monitor or anything like that. So they were giving me pain meds. They were giving me blankets upon blankets. And unfortunately, what ended up happening was I had actually been bleeding out. So my OB, who thank God had come on shift in the morning, reviewing the records of the hospital, saw that I was in the ER. He came down and was like, hey, what's going on? I hadn't been contacted because the ER was just like, oh, it's a miscarriage. We don't need to call the OB. And he pulled back the blankets, and underneath all of those blankets, blood just spilled out onto the floor. All I remember of any of this was him screaming at everybody and then waking up in the ICU. And I remember thinking, if this could happen to me as a clinician coming in, telling people something is wrong and them minimizing my experience, it can happen to anyone. And it still happens to many people to this day. And it almost took my life. And I imagine that many women die unnecessarily because of it.
Well, So sorry for your loss. And thank you so much for sharing such a powerful and vulnerable story. And I think for many of our listeners, a very familiar one. Tell us about how that experience and not being listened to, not being heard, how should we phrase what that moment was like for you? And what do listeners need to know about being in the emergency room or with their healthcare professional?
Yeah, it's a challenge because, we emphasize advocacy. And then sometimes when we're constantly telling people you need to listen or this isn't right, it can actually make them dismiss us more. So we have to be very careful in crafting how we speak, which is unfortunate to get our best efforts across. And I will always tell women who feel like they have failed in getting their goal that I too failed in getting my goal at that time because I was in such an emotional state that I was not even capable of advocating correctly for myself. So we are going to fail in communicating our needs. That's going to happen, but we have to continue trying and improving upon it each time. Every time we do, it provides practice and it provides a foundation for the next time. That's hard to tell women that there's going to be those failures because it's almost a learned helplessness, right? Like you didn't get what you needed the first time. So why should you go back? Why should you try again? And there is moments of hope in trying again. And so that's the challenge that I hope that this conveys is that I could have easily taken that situation and also been like, what's the point? Women aren't going to be heard. They're not going to be listened to. This is never going to change. When in reality, it can change and it can help the next person. So I tell all the women that I encounter that you carry the women from generations before with you. They show up with you to your appointments. They are there with you. You are never alone. They went through that so that you can have a successful appointment so that you can be heard in the future. So people who feel alone going through those appointments know that you carry all these women who have struggled on this journey and they are with you in those appointments.
What a powerful metaphor to kind of visualize and feel in those moments. Let me ask, is there any benefit to maybe those around you, whether it's a partner, caregiver? I'm thinking about maybe I'm the father of somebody who has hemophilia B. When it comes to advocacy, what's their role in being there present with someone like yourself in that moment?
Yeah, and it's a difficult perspective because a lot of men feel like these are women's issues, these are women's conditions. What role can I play? I don't have a uterus, I cannot carry children, but the role is to be there, and not just be there, but when you feel like they're not being heard, step in and repeat what it is they are saying until there's an answer. Because we unfortunately, even in 2026, have this notion that if a male is angry, you have to address that versus a woman who is angry. So
Right.
a father or a husband being angry is scarier to clinicians than a woman being angry, which it's really in that conversation that if you feel like they're not being heard, then you need to repeat it so that they can be heard and you carry that voice and support. Because some people, they don't say anything, and that is sort of silent agreement. And people take that as, well, he must think that this is also an exaggerated symptom because she keeps complaining about this. And your role as a male is to say, no, this is not normal. We live with this. We suffer with this as a family. It impacts me as well. And we need to address this. So it's really important that men show up because without men, this is not possible. This is not a women's only effort. Without men, we will not make any progress.
Yeah, and I'd like to speak a little more to that because during our pre-call, I had mentioned, I'm a male interviewer interviewing a female about female, blood-related issues. And, you said something really profound for me, which was along these lines of like, well, it is our role to take part in being educated on the medical side of it all. So can you speak a little more to kind of like that role and how if I'm a male and I'm uncomfortable, what are some steps I can take to get to a place of being able to be a better advocate for my daughter or my wife or my partner in those moments?
The biggest thing that is going to help is to also be engaged in the education, because we've, as a society, have set up this scenario where menstruation is a stigmatized, non-talked about thing. So men are like, oh, no, I'm not going to talk about that. And when you don't talk about it, you can't recognize the signs that they're suffering. You don't know what you're looking for. And when the time comes that you're in that discussion with someone, with a clinician, you will not feel confident speaking out because you won't know normal from abnormal. So I encourage people, when you go to a conference or an educational session, such as we have coming up in April, which I will be presenting, so many people can come to that session and learn. And when you know and you learn and you have that education, then you have that confidence to say, this isn't right and this isn't normal based on what I know, instead of, well, this is a conversation between them because this is a topic in which I'm not well versed.
Maybe speak a little bit to this is the idea of like a stupid question, or it might feel like a stupid question. Can you maybe talk a little bit about what is that entry point for someone? Like I'm at the conference and I see the Women Bleed Too booth and I'm uncomfortable. What's a question I can go ask to kind of help break that barrier for ourselves?
Yeah, you'll be amazed at how supported you will be if we, in our just genuine nature, we approach a booth like that and we say, these conversations make me uncomfortable, but I'm here and I want to learn. And what do you think would be best? How do you think it would be for me to start? What, in your opinion, do you think I should start with? And that kind of opens the conversation from whomever's there to say, hey, we have this resource and this information. You can start here, or we have these programs, or we have these sessions. It's opening that door to the conversation, which I know it can be scary and hard to do. But if you imagine all of these people come to these events hoping that someone like you will come up and ask a question because they do want to spread this awareness and education. So there is no such thing as a stupid question. There are only unanswered, unresolved, and silent issues and suffering that if you don't ask that question, just continues on.
Yeah, and I guess what I'm hearing is if you don't have the question, maybe just acknowledge how uncomfortable you are, and that can even be the entry point to education, like you're saying. So thank you so much for all that. And I think what I wanted to talk about now is a lot of the work you do focuses on language as a barrier to care, and specifically that word carrier. So can we talk about why that term is problematic for women and girls in the bleeding disorders community?
Yeah, so I stopped using the C word many years ago because it caused so many problems and it causes so much confusion, and it really does a disservice to women in bleeding disorders, because in no other disorder in which we have individuals who can suffer from the condition do we as clinicians go out in literature, in research, and refer to it as carrier. And what I mean by that is, we talk about women gaining care and accessing care, but then we call them carrier, and then there's confusion about what does that mean? Are they low? Are they not? Are they having symptoms? Are they not? And we are trying to splice that out, but I think we just have to leave that word behind entirely. In my practice, I've taken care of patients with sickle cell trait. And you have a conversation about what that means genetically, how you might have to assess that individual for other things, for risks. And you have others with alpha thal trait who you also have to educate. And it may manifest in them in a certain way. And you have to monitor them for iron deficiency because things don't always look the way they are. But we call those traits. So in women with this, it should be identified as trait. And then from there, we evaluate whether they are expressing the worst of it, or we need to provide the education on the genetic potential in the future for them so that we can have these conversations that aren't shrouded in our inability to move on. We've spent so much time defining carrier that we've spent almost no time in the research of how do we approach them, how do we treat them, and how do we evaluate that treatment on an ongoing level. So there's no care guidelines, there is no pathways, and there is no algorithms even set out by the American Society of Hematology in this regard. There are many papers on the definition of carrier, and I just feel that we just need to leave that behind because we're just going to spend another decade talking about it instead of moving on and moving forward with women have mild hemophilia or they have moderate hemophilia. And in my own experience, I actually had dropped hemophilia as well So I had women who were presenting to the ER with lower levels and not being heard, and they weren't even contacting myself. And what I ended up doing was changing their medic alerts to say factor 8 deficiency, factor 9 deficiency. And it had an added benefit for men as well, because I found out that men who were presenting to hospitals that we were not affiliated with were actually being appropriately treated, because I had some people with hemophilia B who were being treated with factor 8. As people type in hemophilia or anti-hemophilia or whatever, hemophilia B doesn't tell you it's factor 9 deficiency. But if you make a medic alert that says factor 9 deficiency and the percentage, it is a clear message. It is a clear statement, and it provides that information. And these women then came back and told me, well, they saw that it was factor 8 deficiency, but that didn't clue them into that it was hemophilia and all the stigma that comes with that word. And so all they saw was it was factor 8 deficiency. I better make a call.
Mm.
And so that changed everything for them. Just semantically, that language improved their odds of having a better outcome.
Yeah, no, it's so interesting because so many of the interviews I've conducted, there is a knowledge gap with a lot of healthcare providers when it comes to hemophilia. And I think it's so incredible that just these tiny shifts in language can get you the care you need. I know specifically like with EMS services, there are some that they can't even treat a hemophilia or a hemophilia incident because it's not taught, right? And going back to that word carrier versus trait, to me, it seems like carrier almost assigns fault to the mom, and maybe speak a little bit to that.
Yeah, so women have carried this burden of guilt since it's been documented, and not even the queen could, as a queen of an entire country, try to escape fault. So they blamed Leopold's condition on her desire to have pain control during childbirth. So if you can imagine being the queen of a country and having your son's disorder being blamed on your pain control. So the guilt goes way back, and they carry this forward, and it gets carried through as generational trauma. Mm-hmm. But I always have to remind people, men and women pass this on genetically. Fathers pass it on, but we don't talk about father guilt. And I recognize that for men, this is a very important gap that they have as well that we are not addressing. So there are men who, in my opinion, would benefit from these conversations as well, because they're passing this on and seeing the suffering of their daughters. But everyone talks about, women's guilt and passing it on, and everybody passes this genetic trait on.
And I know one thing you wanted to touch on was the idea of like oral contraception. So talk to us a little bit about like the stigma there in clinical discussions. And I guess the context is when it's being used as bleeding management, not necessarily contraception.
Yeah, so that's another one that is a great example to kind of go back to what you had spoken of before. It assigns this idea of the outcome. So it assigns this blame of like, they're using it for sexual reasons, and they're being promiscuous, and so therefore they are on it, and it's being used for birth control and all that entails with it, and all of the access that can be limited by that particular use. And in this setting, we're using it for hemostatic control. So we are not using it to prevent birth. We inform and educate women that a side effect of this treatment results in the decreased potential for them to become pregnant. But we have a lot of other medications that could accidentally terminate a pregnancy or cause issues as well, and we don't label them by their outcome. It is only in oral contraceptives that we assign this notation to what it's used for, as opposed to other medications that we do not ascribe this sort of symbolism to it. And so I use the term hormones because they are hormones at the end of the day, just as testosterone is a hormone, estrogen is a hormone, and progesterone is a hormone. And men have these hormones too. And that's interesting that I always encounter that people forget that. They think men only have testosterone and women only have estrogen and progesterone, but that's not the case. We both have, but we have all three. And so if you treat someone, you're utilizing hormones to get to a certain outcome.
Again, is in such a brilliant, simple pivot away to a semantic that is just less of a stigma, right? And whether you agree with the stigma or not, it is there, right? It's really brilliant work. So can we let's shift focus and talk specifically about the hemophilia B community. And first, I want to ask, how did you get connected to the hemophilia B community?
Yes, I can't recall what year it was now. It might have been at least 8 years ago. I was contacted by a member who said, I heard you have this presentation for women that talks about sexual health and bleeding disorders, but does not undervalue it or speak of it superficially. And I said, that is accurate. I do have a very medically accurate presentation for women to understand bleeding that can occur during sexual intercourse. And so they flew me out to one of your guys' national conferences and I spoke on it. And it was a great opportunity to bring that education. And I still to this day provide that content because it's been well requested. It's been an interesting journey with that content because many patients had asked, national organizations to provide the content. And some outright said those years ago that they didn't want to be associated with the stigma of the content. Some manufacturers had said that they did not want to be associated either. So it was an interesting journey for me hearing all these no's. And then finally, some people who were like, people are asking for this. Let's bring them the content. So those early pioneers in this organization who said, let's bring her out. This is a risk that we're going to take and see what happens. And then it just kind of grew and blossomed from there.
Yeah, and I think it also speaks to, the coalition. It's real life. We bring discussions, we bring education because that's what we're experiencing, and we can't shy away from the stigmas or what society chooses to label something as. So, again, the fact that you are in this community and welcome and continue to provide such important education is just so incredible. So I guess maybe what do you feel like is the biggest problem or hurdle, maybe semantically or in the doctor's office when it comes to hemophilia B?
I think the challenge really at this point in time is where do we go from here? In my opinion, the comprehensive model was really needed and effective for the time in which it was implemented. But in 2026, is this the most efficient care to not only get the outcomes that we need, but provide that care in a meaningful way? And what I mean by that is, with lower joint bleeds is a requirement to say you have to see a physical therapist or you have to see, a social worker. Does that need to move into a model that meets the needs of people in today's time? I don't think that it has evolved to meet those needs. In Europe, and this was just presented at EAHAD, they are moving towards an accountability of their national centers. So they're standardizing their centers because what often happens is experiences vary widely. They vary regionally, and that really shouldn't happen. There should be a expectation of care that you will receive when you are accessing institutions that are centers of excellence. And so there should be a standardized guideline that is agreed upon, and then those can be evaluated to see whether or not they're meeting that metric or not. So that's a great way to say, yes, this matters, and yes, it is impactful versus just, yes, it matters. Right now in the US, there really isn't the second step of, is this being effective? And we have a real big equity problem with women and their ability to access the same equitable level of care that we provide men. And so these women sit outside of a system that was not designed to exclude them, but it has over time evolved that way.
Yeah. And I think one thing that comes to mind, and I believe it's within the last, I want to say 3 years, but they finally started testing, menstrual products with actual blood. That was something. Have you heard that?
Yeah, so I actually bring this up in my menstruation presentation, the idea that, we are not Smurfs and we do not bleed blue. We need accurate representation, even within commercials. But yes, even the absorptive nature of the products that are utilized and how they are built, what they are made with, because sometimes they're made with formaldehyde, which is not something you should continuously expose somebody to. But in bleeding disorders, people sometimes will have really long periods if they don't have good management and care. So they have to use these products with an exposure that is much higher than any other woman who would be utilizing them. And so it is advancing. I really appreciate that there's much more options for women than there ever was before. But I also worry because with more options and more protection, there is ability to hide it more. So women have this notion that using a pad and a tampon as a bleeding disorders patient is completely normal, and it is not. Wearing an overnight diaper while it protects your sheet in your bed does nothing to protect your quality of life. And so while the products are improving, the care is not behind it improving as well.
So I guess as we kind of start to wrap up here, can you maybe highlight a story or, a personal moment that kind of illustrates why this matters so deeply to you?
Yeah, I mean, there are so many to speak on, but when you have a woman who comes to you, and I've had many where in the beginning session, it's they feel bad because they're very angry and they may even yell at you. And some clinicians have much discomfort around that. And they're not yelling at you. They're yelling with the generations of past that are showing up with them, as I discussed before. So as a clinician, you have to be strong enough to recognize that this is their venting, move forward. And then once you get to the next appointment and you start talking about, where are we with your levels? What is the plan? Here are the risks. Here are the benefits. But the really monumental piece for me is the patients who actually it's changed the very fiber of who they are, which sounds very grandiose. But I've had patients where when you get them fully recovered and they've, for the first time, stepped out of iron deficiency anemia for the first time in 20 years, and they remember who they are, it's a phenomenal experience to walk that path with them because they've forgotten what it felt like to be normal. And I don't think that's anything that you can really describe to someone. You have to see it for yourself. But seeing those moments where finally with treatment and removal of iron deficiency, which causes so many issues for so many of these women that expands beyond what you think it would, it can change their whole personality. And it's an interesting concept to know that perhaps we don't even know these women because we haven't provided them the tools to show up as themselves.
Yeah, and I'm sure those moments are kind of what help you get out of bed some mornings.
Yes, absolutely, because there are still the barriers and the other things that we have to overcome. And so those are the moments where you're like, okay, this is possible. And every person deserves this opportunity to experience the same thing.
Absolutely. I guess as we wrap up, what's your message of hope right now in the bleeding disorders space, especially for women and girls?
Yeah, I think we are well positioned at this time period to really get to a point where we're making real progress and not just having PR conversations about women with bleeding disorders, being in vogue. I know some programs have existed for 15 or 20 years, but really haven't moved the needle. So I do feel like now we are in that position to really get that moving forward. And it is my hope that women have not lost hope and can also drive that change right along with everything else. So I am more hopeful than I have been in the past, with the caveat that I recognize that challenges still exist.
Thank you so much for being here today on what I assume is a lunch break. So I hope that you can go back to lunch before you finish the rest of your day. And thank you again so much for being here, Amber Federizo.
Thank you for having me.
Of course. This has been Boundless B, the Hemophilia B podcast, the podcast standing with you from a family like yours, presented by the Coalition for Hemophilia B and in partnership with Balancing Life's Issues. To learn more about how to advocate for yourself or someone you love and to stay connected to your community, visit hemob.org. Thank you for listening to Boundless B, the Hemophilia B podcast, the podcast standing with you from a family like yours, presented by the Coalition for Hemophilia B and in partnership with Balancing Life's Issues. Produced by me, Kai. Got an idea for the show? Send us an email at podcast@hemob.org, and don't forget to stay connected to your community at hemob.org. Anything else to add, Miles?
Yeah.
This episode of Boundless B, the Hemophilia B podcast, presented by the Coalition for Hemophilia B, is made possible in part by the support of CSL. We thank CSL for their continued commitment to the bleeding disorders community.